everyone, myself Dr. Akash Karwa. In this CC session, we will be discussing today on cardiac sarcoidosis. A brief introduction. Sarcoidosis is an enigmatic disease because its exact cause and pathogenesis remains hidden despite decades of focused research. Its signature lesions are non-cascading granulomata. It is a systemic granulomatous inflammatory disease that mostly affects the lungs. Cardiac involvement in up to quarter of patients and maybe the sole organ involved. Cardiovascular disease, it is a primary cause of morbidity and mortality in sarcoidosis. Cardiac sarcoidosis is usually present in tandem with extracardiac involvement. It is a set of pathologies that occur owing to both active inflammation and as well as granulomatous scarring of the heart. No cardiac structure is safe from granulomas, but myocardial infiltration does the most of the harm. Remission occurring in over one half of patients within few years of diagnosis. However, the remaining patients may develop chronic disease that lasts for decades. Diagnosis of cardiac sarcoidosis remains a challenge with no prospective data to guide treatment. Advancements in cardiac imaging, increased recognition of cardiac sarcoidosis among patients with heart failure or arrhythmias is used to identify patients who can benefit from further therapies. The increased prevalence, associated morbidity, including advanced stages of heart failure or refractory arrhythmia, as well as treatment implications like immunosuppression, warrant raised awareness of cardiac sarcoidosis in the heart failure community. Epidemiology, prevalence of the disease varies from 20 to 60 per 1 lakh. In India, it is 10 to 20 per 1 lakh. Underdiagnosed due to tuberculosis. Higher rates occur in Ireland and Nordic countries. Rare age of presentation less than 18. Median age is around 55 years. Sarcoidosis can affect virtually every organ of the body. The lung is most commonly affected. The presence of cardiac involvement is influenced by race. It is approximately 25% in Japanese, and in USA it varies from 2 to 5%. Pathogenesis, it is an immunologic reaction against a novel antigen in a genetically susceptible individual. These antigens are phagocytized by macrophages and are presented to CD T helper cells. Secretion of interleukin 2 and interferon gamma causes activation of type 1 helper T cells. Th1 cells plays an essential role in modulating the immune response by increasing inflammatory cytokines and cytokines production, including interferon gamma, transforming growth factor beta, IL-2 and IL-12. It is associated, not causative, but associated with Propionibacterium acnes. We can see this. This is a unidentified antigen which has not been identified in a genetically susceptible individual. This presents to the body and it is detected by antigen presenting cells, which starts an immune reaction with the help of CD4 T cells, involving further secretion of cytokines like interferon gamma, interleukins, and formation of a non-caseating granuloma. This granuloma over a period of time can undergo resolution or can form scars or fibrosis. There is an immune paradox. It is paradox because the granulomas in sarcoidosis has abundant CD4 T cells, but the peripheral blood shows lymphopenia, and the tuberculin skin test is false negative because not enough circulating peripheral CD4 cells for immune response, that is the cutaneous energy. Genetic predisposition, co-twin of affected twin carries greater risk of developing sarcoidosis than general population. Case control etiologic sarcoidosis study, risk of first and second degree relative of a sarcoidosis patient was 4.7 times that of controls. Genetic studies, early onset sarcoidosis linked with defects of CARD15 gene. Pathology, there is the formation of non-cascading granulomas. There are 3 successive histological stages: edema, granulomatous inflammation, fibrosis leading to post-inflammatory scar. These 3 stages can be simultaneously present in a patient. The ventricular myocardium is most commonly affected site. LV free wall and papillary muscle more than basal IVS, more than RV free wall. Involvement by the atria, walls, coronary arteries and pericardium has been described. So the pathology we can see normal myocardium with intercalated disc and a single nuclei in the fibers, whereas the other one, the non-crustacean granulomas and multinucleated cells consistent with CS. Various clinical presentation. First can be CS hidden until autopsy. If a patient undergoes a unexpected sudden cardiac death, he is only diagnosed only at the autopsy, might not have any symptoms during his life. These individuals are free of both known sarcoidosis and cardiac manifestations while alive, or their symptoms and signs of heart disease have been misdiagnosed on lifetime examinations. Among the 351 cases of cardiac sarcoidosis detected in Finland from 1998 to the end of 2015, 62 were diagnosed post-mortem, and in 38 patients, sudden cardiac death was the first and only manifestation of cardiac sarcoidosis. Second presentation can be with CS cardiac sarcoidosis with dominant extracardiac sarcoidosis and no or minimal cardiac symptoms. Found on routine screening or in examinations for mild symptoms and abnormalities on ECG. A study reporting post-mortem and cardiac magnetic resonance studies uncovering myocardial involvement in 25 to 30% of all sarcoidosis and even in 9% of patients without symptoms or ECG abnormalities. Clinically manifest cardiac sarcoidosis. Prevalence of isolated cardiac sarcoidosis has varied from 3% to 43%. Cardiac involvement as the first or only organ manifestation, that is de novo or clinically isolated cardiac sarcoidosis, implies more serious disease than cardiac sarcoidosis appearing on top of extracardiac disease. Clinical scenarios to suspect cardiac sarcoidosis. For a patient with no prior history of extracardiac sarcoidosis, sustained monomorphic VT or aborted sudden cardiac death of unexplained etiology, advanced AV block in individuals 60 years of age or younger, unexplained regional ventricular wall motion abnormalities, ventricular wall thinning or aneurysm, unexplained cardiomyopathy or heart failure. In a patient with a known history of extracardiac sarcoidosis, when to suspect cardiac sarcoidosis? When the symptoms of palpitations and syncope are present, ECG abnormalities like premature PVCs and PACs, bundle branch blocks, conduction diseases or arrhythmia, ventricular wall motion abnormalities or dysfunction, and perfusion defects on cardiac imaging. Clinical manifestations, dyspnea, most common symptoms, most common manifestation is the high-grade AV block, palpitations, heart failure, LV dysfunction, sustained VT. Clinically manifest cardiac sarcoidosis. Clinical features of cardiac sarcoidosis depend on the location, extent and activity of the disease, preferentially affect the myocardial layer more than endocardium, pericardium and valves. Most common site, septum, free wall, papillary muscles, RV free wall in the areas not commonly involved by ischemic heart disease. Manifestation, AV conduction disease, arrhythmia, cardiomyopathy causing heart failure. Less commonly, pericardial, valvular and coronary diseases. Palpitations like can present with SVTs and ventricular arrhythmias. Presyncope, syncope due to AV blocks, arrhythmias. Fatigue, dyspnea and orthopnea due to heart failure and cardiomyopathy. Manifestations depend upon the location and extent of granulomas. AV block, high-grade AV block due to conduction system infiltration, arrhythmias, AF, SVT and VT due to re-entry circuits in scarred myocardial areas, automatic and triggered arrhythmias due to active inflammation. Multiple VT morphologies are common because many areas can be involved simultaneously. Heart failure due to widespread LV infiltration, restricted filling due to edematous or fibrotic LV walls, myocarditis or cardiomyopathy. Rarely mitral regurgitation due to LV or mitral annular dilatation, scarred LV wall restricting valve closure, or from granulomas invading the valve leaflets. Infiltration of the RV may masquerade as AVRD. Angina like chest pain can occur and is usually attributed to impaired coronary flow reserve from compression of the myocardial microvasculature, but granulomatous coronary arteritis is also possible and rarely can present as an acute MI with angiography showing normal findings or either dissection or total occlusion of a single coronary artery. Distribution of different presenting manifestations. Main presenting manifestations remain AV blocks and heart failure, and with significant proportion patient presenting as a sudden death, and most common cause of death is sudden cardiac death. Conduction system disease, most common clinical presentation, AV node, bundle of his, intraventricular conduction system involvement, range from it can range from PR prolongation to first degree AV block to complete AV block. Usually high grade AV blocks are present. Sarcoidosis should be highly suspected in a younger patient presenting with CHB. Up to 40 to 45% of cardiac sarcoidosis patients have a conduction system disease. Tachyarrhythmias, ventricular arrhythmias, non-sustained or sustained, second most common presentation. Up to 30% of cardiac sarcoidosis cases. Sudden death can occur in around 25 to 65% deaths. Myocarditis, cardiomyopathy and heart failure in early inflammatory stages or late fibrotic stages can manifest as cardiomyopathy with reduced ventricular function with presenting symptoms of congestive or low cardiac output. In early stages, it is due to the edema of the myocardium causing heart failure, and in late stages due to widespread fibrosis and scarring. It can present as LV systolic dysfunction, predominant RV systolic dysfunction, or heart failure with preserved biventricular systolic function. A diagnosis of heart failure at presentation signified a poor outcome with 10-year transplant-free survival of only 53% compared to 83% for total cohort. For patients with known extracardiac sarcoidosis, a recent retrospective study found that the 10-year incidence of clinical heart failure was 3%, approximately twice that of general population. Predictors of sudden cardiac arrest. Sudden cardiac arrest is a very catastrophic manifestation of the disease. Occurs mostly in patients aged less than 40 years with odds ratio of 1.01. In patients of African American individuals, patient who has AF, patient who presented with heart failure with preserved ejection fraction, LBBB, heart failure with preserved ejection fraction of with the odds ratio of 2.37, RBBB, fascicular blocks, Mobitz AV block, and CHB. CHB remains the most significant predictor of sudden cardiac arrest. Extracardiac symptoms and symptoms that guide towards the diagnosis. Cough, dyspnea on exertion, chest pain suggest pulmonary involvement. Any skin rash including nodules around eyes, nose, ears, cutaneous presentation of the disease, sensory hearing loss, vertigo, headache, numbness or weakness can suggest neurological sarcoid. Elevated calcium or vitamin D due to calcium and vitamin D dysregulation. Elevated liver enzymes, eye pain, redness, light sensitivity, because of the ocular manifestation of the disease. Diagnosis, the triad of compatible clinical characteristics, proof of histology, and exclusion of other diseases required for diagnosis. The diagnosis should be suspected if unexplainable second or third degree AV block, sustained ventricular arrhythmias, or heart failure. 20 to 34% of idiopathic higher grade AV block in middle-aged individuals, a nearly similar proportion of idiopathic ventricular tachycardias, and 5% of mixed ventricular arrhythmias, including frequent premature beats. In pre-existing sarcoidosis, elevated cardiac troponins, natriuretic peptides suspect cardiac sarcoidosis. Extracardiac sarcoidosis patients should be evaluated for cardiac sarcoidosis because cardiac sarcoidosis remains the most common cause of morbidity and mortality in those patients. Criteria for diagnosis of cardiac sarcoidosis. This criteria given by the Heart Rhythm Society. Definite CS, histological diagnosis from myocardial tissue with no alternative cause identified. Probable cardiac sarcoidosis. There is a histological diagnosis of extracardiac sarcoidosis, and one or more of the following is present. That is steroid or immunosuppressant responsive cardiomyopathy or heart block, unexplained reduced ejection fraction, unexplained sustained sustained VT, morbid type 2 second degree heart block or third degree heart block, patchy uptake on dedicated cardiac PET, late gadolinium enhancement on CMR, or a positive gallium uptake. Other causes for the cardiac manifestations have been reasonably excluded, can be suspected. This the diagnosis criteria given by Heart and Rhythm Society. This is Japanese Circulation Society. They have given certain guidelines. Isolated possible cardiac sarcoidosis, gallium scintigraphy or FDG PET reveals abnormally high tracer accumulation in heart, and at least 3 other criteria of the major criteria which are listed below are satisfied. Clinical findings that satisfy the following strongly suggest the presence of cardiac involvement. 2 or more of the 5 criteria are satisfied. These major criteria are high-grade AV blocks or fatal ventricular arrhythmias, basal thinning of the ventricular septum or abnormal ventricular wall anatomy like ventricular aneurysm, thinning of the middle or upper ventricular septum, regional ventricular wall thickening, or LV contractile dysfunction, EF less than 50%, 67 gallium citrate scintigraphy or FDG PET reveals abnormally high tracer accumulation in the heart, gadolinium enhancement MRI reveals delayed contrast enhancement, that is LGE. Minor criteria are abnormal ECG findings of ventricular arrhythmias, that is non-sustained ventricular tachycardias, multifocal or frequent PVCs, bundle branch block, axis deviation or abnormal Q waves, perfusion defects on myocardial perfusion scintigraphy, endomyocardial biopsy suggestive of monocyte infiltration and moderate or severe myocardial interstitial fibrosis. So various test or diagnosis tools required for the diagnosis. ECG, abnormal in patients with clinically manifest disease, heart block or ventricular arrhythmias, conduction blocks, high degree AV blocks, isolated bundle branch blocks and fascicular blocks. RVB is more common than LVB. Also non-specific STD changes, pathological Q waves, and rarely an epsilon wave can occur. ECG is abnormal in only 3.2 to 8.6% of patients with clinically silent cardiac sarcoidosis. Continuous ambulatory ECG monitoring such as Holter may help detect arrhythmias and response to immunosuppressive therapy. Echocardiography. Abnormalities are variable and usually non-specific. Interventricular wall thinning, especially of the vessel IVS, thinning is most common. Less frequently, increase in myocardial wall thickness, simulating LVH or resembling SCM, LV or RV diastolic and systolic dysfunction, isolated wall motion abnormalities, basal septal thinning and aneurysm. Regional wall motion abnormalities are usually seen in non-coronary distribution, impaired LV global longitudinal strain. Diagnostic and has a prognostic utility as well. We can see this basal septal thinning, MR, myocardial pericardial effusion, pulmonary hypertensions, but the most common remains RWMA. GLS in cardiac sarcoidosis. LG was associated with reduced GLS and with reduced E/A ratio. No difference were noted in other TT parameters as the patients had normal EF. GLS magnitude inversely correlated with LG burden. Cardiac sarcoidosis is associated with significantly reduced GLS in presence of preserved LVAF. Part of the TT study performed to screen for, it should be a part of TT study to perform for screening of cardiac sarcoidosis. Biomarkers, most very commonly used, angiotensin converting enzyme ACE levels are elevated in around 60% of patients with sarcoidosis, but they lack sensitivity and specificity in diagnosing or managing sarcoidosis. New studies are now focusing on other biomarkers to assess disease activity. Neopterin remains one of them, and it's especially soluble interleukin 2 receptor levels have been shown to significantly elevate in active disease. Highly sensitive troponin levels are also raised. Cardiac MRI, it remains the mainstay of diagnosis of sarcoidosis. It provides information on structural abnormalities like wall thinning, aneurysm, chamber dilatation, LV-RV function, and an assessment regarding the presence and extent of myocardial scar. The involvement is usually patchy and multifocal with sparing of endocardial border, and it is in a non-ischemic pattern. Late gadolinium enhancement, LG, is the most common in basal segments, particularly of the septum and lateral wall, and usually in the mid-myocardium and epicardium, but transmural involvement, subendocardial and RV free wall may also be involved in some cases. No specific pattern is diagnostic. Studies have shown sensitivities between 75 to 100% and specificities from 77 to 85% with clinical cardiac sarcoidosis diagnosis, surrogated for myocardial histology as the reference. Patel et al. Described patterns of LG in patients with extracardiac biopsy proven sarcoidosis. 86% of the patients had at least one region with LG in a non-ischemic pattern, but subendocardial LG typical of for coronary artery disease was also noted as representing cardiac sarcoidosis in absence of obstructive coronary disease. So in 2014, the Heart Rhythm Society, they specifically mentioned that there is no specific pattern of LG that is pathognomic for cardiac sarcoidosis, and even a pattern that is typical for prior myocardial infarction can also present cardiac sarcoidosis. Location of LV involvement within the LV wall. Within the LV wall, subepicardial in 98% patients, mid-myocardial, subendocardial or transmural. The involvement is multifocal. Usually it is a multifocal involvement more than unifocal involvement. We can see the cardiac MRI images of patients with cardiac sarcoidosis who presented with third degree AV block with normal RV and LV function. In the first image, we can see the short axis Attack-Cce image showing thickened interventricular septum. The T2 weighted image is showing myocardial edema which indicates active inflammation. In the third picture, we can see LG image showing transmural septal, papillary muscle, and local RV free wall involvement. This is another images of a patient with who presented with third degree AV block and depressed LV function. Cardiac sarcoidosis was verified by endocardial biopsy. We can see late gadolinium enhancement with patchy involvement of the ventricles. FDG PET imaging. FDG, a glucose analog to differentiate normal and active inflammatory lesions, where the activated pro-inflammatory macrophages show a higher metabolic rate and glucose utilization. No individual clinical finding is pathognomic for the diagnosis. Focal on diffuse FDG uptake pattern suggest active cardiac sarcoidosis. Disease activity marker it represents a disease activity marker to guide the CS therapy. It should be performed at a center with expertise in CS imaging protocols, because a false FDG uptake can hamper the diagnosis. FDG PET CT of a patient with trifascicular block and depressed LV function. CS was verified by endomyocardial biopsy. We can see in the C image the FDG uptake there is a mismatch pattern. CMR PET, though CMR is the most robust imaging to detect scar, it has limited use in detecting the inflammation. Inflammation is necessary to detect because it guides the treatment, whether to use immunosuppressants or not. Technology has been developed to perform fused fused PET and CMR, which enables concurrent imaging of two stages of the disease, the inflammation and scar. We can see combined CMR and PET images. CMR is useful for showing the LGs and the fibrosis and scar. PET, in addition to showing scar, also shows the area of active inflammation. Whenever the active inflammation is present, the therapy of immunosuppressants is very good for the patient. This is in brief. When there is a suspected case of cardiac sarcoidosis, first investigation is performed, that is cardiac MRI. Usually cardiac MRI is performed. Then depending on the LG, we perform PET and endomyocardial biopsy. Endomyocardial biopsy of a lymph node or lung biopsy is typically targeted first due to higher diagnostic yield and lower procedural risk. If negative extracardiac biopsy, endomyocardial biopsy may be required to confirm the diagnosis. Endomyocardial biopsy has low sensitivity due to focal nature of the disease. It reveals non-cascading granulomas in less than 25% of patients with cardiac sarcoidosis. To increase sensitivity, electrophysiological, that is electroanatomic mapping, or image-guided PET or CMR biopsy procedures are now recommended by consensus guidelines to increase positive biopsy rates up to 50%. This is the endomyocardial biopsy showing non-necrotic granulomas and isolated giant cells with or without surrounding lymphocytic or granulocytic infiltration with combined myocardial fibrosis. So this is a diagnostic flow chart for the diagnosis of cardiac sarcoidosis. First, high clinical suspicion is necessary whenever a patient less than 60 years presents with ventricular arrhythmias of multiple morphology or complete heart block. Screening, cardiac screening of patients with extracardiac sarcoidosis. The American Thoracic Society recommends symptom history and 12-lead ECG for routine screening and echocardiography in addition. CMR and PET, FDG PET if abnormalities in screening. Some predictors of mortality. Most important remains the LV ejection fraction. Others can be the NYHA class during presentation, left ventricular end diastolic diameter, sustained ventricular tachycardia, cardiac involvement as the first or only organ manifestations, that is de novo or clinically isolated CS implies more serious disease than CS appearing on top of extracardiac disease. The differential diagnosis in India, the most common differential diagnosis remains tuberculosis. Other can be viral myocarditis, Lyme carditis, and giant cell myocarditis, which presents with conduction system disease, arrhythmogenic cardiomyopathy. RV sarcoidosis must be distinguished from RV dysfunction due to sarcoid-associated pulmonary hypertension. Advanced cardiac sarcoidosis can be mistaken for dilated cardiomyopathy. Several transplant centers have identically reported that all their cases of cardiac sarcoidosis in explanted heart had pre-transplant misdiagnosed of idiopathic dilated cardiomyopathy and ischemic cardiomyopathy. Of this, tuberculosis remains a very important differential diagnosis because it is very tough to differentiate it from cardiac sarcoidosis. Treatment, the care of clinically manifest cardiac sarcoidosis should be handled in tertiary referral centers. Immunosuppression to control the underlying myocardial inflammation, and medical and device therapy for consequences of cardiac injury and scarring. Advanced heart failure therapies include ventricular assist device and heart transplantation. Immunosuppression, it is initial therapy. Evidence of active inflammation on PET, if it is there evidence of active inflammation on PET, we should initiate immunosuppression. Subclinical disease with absent LV dysfunction, benefit is unknown but can be given. Treatment decision must be individualized in consideration of extent of myocardial inflammation, other organ involvement, and the risk of therapy. Non-specific immunosuppression with corticosteroids constitute the mainstay of treatment. Corticosteroids benefit in severe LV dysfunction, it is less likely. Prednisone at dose of 0.5 milligram per kg per day to start with. Rapidly progressive heart failure, life-threatening arrhythmias, and extensive inflammation on cardiac PET. Short or 2 to 3 days therapy of methylprednisolone 500 to 1 gram per day can be given. Prednisone titrated down every 4 weeks by 5 to 10 milligram until a maintenance dose of 10 milligram per day is achieved. 3 to 6 monthly monitoring, assessing symptoms, LV function, 12-lead ECG, arrhythmia burden, and circulating cardiac biomarkers. ECG changes of active inflammation, including worsening AV block or intraventricular conduction, increased ventricular ectopy, non-sustained VT, and new STD changes. 2D features of disease activity, decreasing EF, new wall motion abnormalities, and increasing mitral regurgitation. Toxic effects of steroids should be monitored. Corticosteroids are discontinued after 12 to 16 months, supposing absence of disease activity. Follow-up after treatment, CMR has a limited role, but repeat FDG PET routinely to follow the activity of cardiac sarcoidosis and to tailor treatment accordingly. It is and it has not shown to improve the either the quality of life or the event survival, but it helps in managing the patients. In a recent study of immunosuppression for suspected active cardiac sarcoidosis, the rate of major cardiac events did not differ statistically significantly between the patients showing complete clearance of FDG uptake versus no response on early PET. Selective PET strategy, that is repeat PET if discrepant clinical observations or insufficient treatment response or relapse is suspected. Annual follow-up for 3 to 5 years and every other year thereafter. Late relapses are possible. Second line, that is steroid sparing therapy, methotrexate, azathioprine, mycophenolate, mofetil, leflunomide, and cyclophosphamide. Methotrexate weekly dose of 10 to 20 mg, azathioprine 1 to 2 mg per kg body weight per day. They are used when corticosteroids have inefficient efficacy or their dose needs a reduction to spare the patients from the toxic effects of corticosteroids. Third line therapy, in patients who are not responding to first line and second line therapy, third line therapy can be used, which consists of biological anti-tumor necrosis factor agents like infliximab, adalimumab, rituximab. So there are certain ongoing trials which are using new drugs are undergoing. Attack-Cce trial using prednisone and methotrexate combination, Magic ART trial using anakinra, J-Acnis trial using corticosteroids alone together with antibiotics based on assumed pathogenetic role of Propionibacterium acnes. Resolve Heart, it is using namilumab, a monoclonal antibody targeting the granulocyte macrophage colony stimulating factor. Treatment of heart failure, GDMT to treat CS related congestive heart failure, corticosteroids if there is proof of active myocardial inflammation. Aggressive immunosuppression and mechanical support may be needed in rare cases of CS related fulminant myocarditis. CRT in patients who have developed dilated cardiomyopathy, LVAD, and cardiac transplantation for terminal AF. Advanced heart failure therapy, studies have shown good post-transplant survival and a similar risk of late complications as the non-CS transplant recipients. Recurrence of CS in allograft is rare and has not resulted in graft failure. Advanced interstitial lung disease may result in sarcoidosis related pulmonary hypertension and may be limitation to heart transplantation candidacy due to concern of for post-operative allograft dysfunction. Regarding LVAD evaluation, RV failure risk should be assessed. Perioperative considerations, risk of adrenal insufficiency and wound healing in setting of long-term prednisone therapy. Control and prevention of symptomatic ventricular arrhythmias and sudden cardiac death. Symptomatic ventricular arrhythmias, the observed effects of immunosuppression on symptomatic ventricular arrhythmias in cardiac sarcoidosis are unpredictable. Still, corticosteroids are recommended if there is proof of inflammatory activity. Antiarrhythmics, amiodarone or sotalol for ventricular tachycardia, started concomitant with immunosuppressions or following an insufficient response. If medical therapy fails, catheter ablation can be considered. Preceding ablation, intravenous methylprednisolone 40 to 80 mg per day is worth if VT storm associated if VT storm is associated with active inflammation. In a meta-analysis of 15 studies involving more than 400 patients with refractory VT, freedom from recurrences was 45% after first ablation and 63% after repeated procedures. 13% to 40% needed epicardial ablation. VT ablation helps control stormy or incessant VTs. Refractory to medical therapy and ablative therapy, bilateral cardiac sympathectomy is considered. Prevention of sudden cardiac death, because sudden cardiac death remains the most common cause of death in patients of cardiac sarcoidosis. Clinically manifest cardiac sarcoidosis have a 10% risk of sudden cardiac death over 5 years of follow-up. In subclinical cardiac sarcoidosis, the risk is lower. Permanent pacing for a high-grade AV block, even despite improvement of conduction with steroid therapy. History of syncope is an ICD indication by the North American guidelines but not by the European ones, which also recommends program electrical stimulation and ICD for inducible ventricular arrhythmias only in presence of LV dysfunction. This consensus recommendation for ICD in cardiac sarcoidosis patients. Class 1 indication remains the prior aborted cardiac arrest, documented spontaneous sustained ventricular tachycardia, or LV ejection fraction less than 35%. Two-way indications are LV ejection fraction more than 35% with indication for permanent pacemaker, history of syncope compatible with arrhythmogenic etiology, inducible sustained ventricular arrhythmias. Long-term outcome and prognostic factors in contemporary studies showing the 5-year and 10-year survival rates in recent cardiac sarcoidosis cohorts with a comparative summary of cohorts characteristic. Although the study populations differ in several key aspects, their 5-year survival prospects are consistently 90% or higher. We can see in these cohorts. To conclude, though Dr. Warfield Longkop impressed upon us that sarcoidosis should no longer be considered a rare entity exactly 80 years ago, the condition is still considered by many to be a rare disease. However, cardiac sarcoidosis is increasingly prevalent and warrants improved awareness. Diagnosis presents challenges due to limited expertise, phenotypic overlaps, and dependence on often elusive histopathology. Recognition of cardiac sarcoidosis carries implications not only for prompt initiation of immunosuppressive therapies to control downstream effect of granulomatous inflammation, but also for adjustment of peritransplant and LVAD management. Interdisciplinary and cross-collaborative approaches are needed to improve our understanding and management of cardiac sarcoidosis. Okay, thank you.